Good morning, ladies and gentlemen, and welcome to the presidential lectures. Just a few introductory comments. First of all, let me introduce my co-chairs, Günter Deutschel, the past president of the International Parkinson Movement Disorder Society, and Oskar Gershanik, the president-elect. Let me remind you of what you've heard many times before. Please silence your cell phones, and photography is not allowed. Faculty disclosure information has been shown on the rotating slides, and there will not be questions and answers for this session. This is one of the signature events of the Society, and it's always a pleasure to recognize both junior members who have made outstanding contributions, and of course some of our most esteemed and respected colleagues. We're going to start with the Stanley Fahn Lecture. Stan Fahn Lecture was created to recognize an outstanding scholar and role model clinician in the field of movement disorders and our co-founder, along with David Marsden. The awardee this year is Dr. Joe Jankovic. Dr. Jankovic is Professor of Neurology and Distinguished Chair in Movement Disorders, Director of the Parkinson's Disease Center and Movement Disorders Clinic at the Department of Neurology at Baylor College of Medicine. Dr. Jankovic was the third president of the International Parkinson and Movement Disorder Society after Dr. Fahn and Marsden. He's the recipient of numerous honors, and since 1991, many of you know him for his founding and ongoing involvement in the annual course, A Comprehensive Review of Movement Disorders in Aspen, Colorado. He has mentored numerous fellows and other trainees, many of whom have become leaders in the field of neurology and movement disorders, and it's a great pleasure for me to introduce Dr. Jankovic, who will speak on shakes, twists, and jerks. Can we diagnose them and treat them? Joe.
Well, thank you, Professor Stern, and congratulations on your presidency and the leadership that you have provided to the Movement Disorder Society. When I was contacted by the Society and was told that I was selected as the 2014 Stanley Fahn Lecturer, I was obviously deeply touched and honored. Then I was asked to provide the name or topic for the lecture, and that was not easy. It was about 6 months ago. I was not really in a mindset of thinking about the lecture, so I tried to think of some generic topic that would give me the freedom to talk about anything. And this is the topic that I chose: shakes, twists, and jerks. Can we diagnose them and treat them? And what I hope to do is share with you some of the things that we are currently thinking about and doing in our center. Now, I must say that the close relationship that I share with Stan Fahn is certainly one of the highlights of my both personal and professional life. Stan was clearly my mentor. He is the one who inspired me to seek movement disorders as my future. And since my early days at the Neurological Institute at Columbia, we have shared a very close friendship. This is taken from a centennial celebration of the Neurological Institute in September 2009. Many of you have seen this picture, which is an important picture because it was taken at a time when the original founders of the Movement Disorder Society met in Hamburg in 1985. This was taken by my wife, Kathy, and it shows some of the founders, including Dr. Fahn, David Marsden, Andy Lees, and Eduardo Tolosa. And that was sort of the beginning of the Society, and since that time, as you recognize, the Society has grown into a major international organization with many, many accomplishments and lots of money in the bank, which is great. Many of you who know me know that I like to take pictures, and this is one of my favorite pictures that I took in Aspen. As Dr. Stern pointed out, one of my joys is to have conversations with Stan during the Aspen course. But in the early days, David Marsden was the co-faculty, so there were the three of us. And this is taken during one of our pleasant evenings in Aspen, Colorado. David Marsden was replaced by Mark Hallett after David's untimely passing, and this is a more recent picture where we feature our most recent edition of the book on movement disorders, which is based on some of the lectures that we give in Aspen. So let me just briefly outline what are some of the topics I thought I would want to cover. So we've been interested recently in some of the sensory aspects of movement disorders. There has been a great deal of attention paid to the non-motor aspects of movement disorders, but very little, I think, has been paid to the sensory aspects. So I will share with you some of the thoughts about sensory aspects of movement disorders. One of our other major areas of interest, especially more recently, is genetics, and I will talk a little bit about some of the genetic discoveries and how they help us diagnose unusual movement disorders. We've been also interested in autoimmune movement disorders, and I will just touch lightly on that topic, and I hope I'll have time to conclude with some remarks about some of the novel treatments of hyperkinetic movement disorders. So let me start with the sensory aspects of movement disorders. Again, this is something that I don't think has received a great deal of attention, even though non-motor aspects of movement disorders have been emphasized in many recent reviews and meetings. An example of a sensory aspect of movement disorder is alleviating maneuver. This has been traditionally referred to as just antagonist or sensory trick, but we, together with Mark Hallett and one of my fellows, Dr. Patel, felt that this is really not an appropriate term because not all of these maneuvers involve sensory input, and they are not really tricks. So we preferred to use the term alleviating maneuver. And here you see some examples touching the face. This woman, if she puts a book or some object on the vertex of her head, she can correct her enterocollis, and there are other examples of patients with blepharospasm using a variety of these alleviating maneuvers. We still don't have a clear understanding of the mechanism of these alleviating maneuvers, but functional MRI studies have provided some insight in that attenuation of the muscle activity is associated with reduced activation of the supplementary motor and the primary sensory motor cortex. This is a study that has not yet been fully published, although has been accepted by JNP, and it's based on our collaboration with the Dystonia Coalition, where over 1,000 patients now have been characterized, patients with cervical dystonia. We examined the videotapes of these patients. They all underwent standardized video protocol. 154 people were studied, and 90% of them reported alleviating maneuvers. 43% had partial improvement, and about 40% had essentially complete improvement in their abnormal postures. Most of the alleviating maneuvers involve touching of the lower face and chin, and this is something quite familiar to all of you. What was surprising to us that there was really no correlation between the improvement by these alleviating maneuvers and the severity of dystonia. Now, there are many other examples of sensory aspects of movement disorders. All of you are familiar with premonitory sensation in patients with Tourette syndrome. Restless leg syndrome is probably the best example of an abnormal sensory motor integration resulting in disabling symptoms. And here we list many other movement disorders that have sensory aspects to them, including Parkinson, dystonia, and many other, I just mentioned, restless legs, akathisia, stereotypies. But I want to draw your attention to this, what I consider sort of a new term for a movement disorder which is very, very common. And I refer to it as a leg stereotypy disorder, or LSD. I think all of you are familiar with that, and as I look in the audience, I actually see some of you having this disorder. It was not really previously characterized, yet it's one of the most common movement disorders. Often it's observed in people who are sitting in a meeting, particularly if it's a boring meeting. These are stereotypic 1 to 2 hertz rhythmical flexion extension movements. They are often familial, so this is clearly a genetic disorder. In contrast to RLS, there's no diurnal variation, and there's really no unpleasant sensation associated with it. Let me show you a video of father and son with this condition.
Left leg, is it right?
Yes, sir. Yeah, it's just, I wouldn't say it's restless, it's just, it's almost a natural thing I don't even know I'm doing most of the time.
When you are sitting in a meeting and you are making this movement in your leg, what happens to people around?
Oh, it's very noticeable. I'm getting comments all the time, I can't sit still, and, you know, it's kind of distracting for others.
Now, sir, you apparently have a similar kind of habit. Let's call it a habit for right now.
Right.
How long have you had it?
My wife would know. I think ever since I met her, I think, you know, I've been very, almost like hyper movement.
Well, your wife said that when you're sitting in church, you
Yes.
have it essentially.
She'll put her hand on my knee to stop me because she says I'm shaking the whole pew where everybody's, you know, sitting. So it must be pretty hard and pretty strong.
So again, most of you are familiar with this, and many of you know friends who have it. How many of you in the audience have it? Quite a few. Look at this. Yet this disorder has never really been characterized, so it's something that we want to spend some time on in the future, trying to characterize the genetics of this disorder and the pathophysiology of this disorder. So let me now shift to another topic, namely how genetic tests can help us diagnose the unusual movement disorders. So let me show you an example. So this is an 11-year-old boy who was able to walk and run until age 8 when he developed progressive generalized dystonia, diurnal variation, myoclonus, bradykinesia spasticity. There was marked improvement in dystonia with levodopa, but he soon developed a wearing off effect and levodopa-induced dyskinesia. CSF studies showed low tetrahydrobiopterin and low homovanillic acid. Family history was unremarkable, except that one maternal grandmother had Parkinson's disease. So we did the usual investigation, including GTP cyclohydrolase, looking for any genetic abnormality that would help us diagnose this dopa-responsive dystonia phenotype together with spasticity. There were obviously some atypical features, so we were not surprised that the GTP cyclohydrolase test came back negative. So here, let me just show you the video of this patient. He clearly has evidence of dystonia, dystonic tremor, and then you can see this stiff spastic gait. In an off state, 5.5 hours after last levodopa, there's a marked exacerbation of his dystonia, and in fact, at the end of the day, he is wheelchair-bound or bedridden because of the severe dystonia. He soon after he was started on levodopa, developed levodopa-induced dyskinesia, as you can see here. We obviously were puzzled by this unusual movement disorder, looked at MRI, didn't see anything specific here except for some white mattered periventricular changes. But we were struck by this thin corpus callosum, particularly in the anterior third of the corpus callosum. And in contrast to typical DRD, on that scan, he had severe deficiency, nigrostriatal dopaminergic deficiency. So that already told us that he obviously doesn't have typical DRD. The functional MRI showed evidence of cortical basal ganglia overconnectivity, as shown here. So we performed whole exome sequencing, and to our surprise, he had heterozygous compound genotype in a gene coding for SPG11. So there were two mutations, E1630X and L23004, which we felt were pathogenic, and targeted SPG11 sequencing of both parents showed that one parent had one gene mutation, the other parent had another gene mutation. So I'm using it as an example where whole exome sequencing can be extremely helpful in diagnosing unusual movement disorders. So hereditary spastic paraplegia due to SPG11 is well recognized. It's usually characterized by spasticity, cognitive impairment, and the thin corpus callosum that I showed you. 7 other patients have been reported in the literature that also had, in addition to spasticity, dystonia and Parkinsonism, but none of the patients had the DRD type phenotype that I showed you in our patients. So we thought our patient was clearly unique, and certainly levodopa-induced dyskinesia can rarely occur in typical DRD due to GTP cyclohydrolase deficiency, but it's uncommon, whereas in this patient it occurred relatively early. So this genetic abnormality expands the characteristics of not only SPG11 but also of DRD. And here I list some of the causes of DRD. Almost everybody first thinks of GTP cyclohydrolase, which is probably the most common cause of dopa-responsive dystonia. But there are many other causes, including tyrosine hydroxylase deficiency, sepiapterin reductase, pyruvyl tetrahydropterin synthetase, ataxia telangiectasia, PARC2, SCA3, and then SPG11 can be added to the list. And all of these have different characteristics that perhaps help differentiate clinically between the different types of DRD, but certainly genetic tests are increasingly important in differentiating the different types of the DRDs. So this is taken from a recent publication from Baylor College of Medicine, our genetics group of whole exome sequencing of 250 subjects. And what was remarkable in that study that 85% of the individuals whose blood was submitted, whose DNA was submitted for analysis, had a neurological disorder. So I think of all the whole exome sequencing tests done, not just at Baylor, but worldwide, clearly neurologic syndromes represent the majority. So I want to draw attention to this paper because it highlights sort of a changing role for us as neurologists and movement disorders specialists in particular. And it says that next generation sequencing demands next generation phenotyping. And I want to draw attention to at least 2 particular points that these authors make. One is that diagnostic skills of medical specialists will shift from pre-next generation sequencing test differential diagnostic mode to a post-next generation sequencing test diagnostic assessment mode. So many of you probably already experienced that when you send a test for whole exome sequencing, it comes back with lots of data, pages and pages and pages of data. And you wonder, well, what am I going to do with this data, particularly if there's not a specific pathogenic mutation found? So I think in the future, we're going to be called upon to make some sense out of this data and rely on our clinical skills and knowledge of the phenotype to interpret this vast amount of genetic information. In that regard, I draw attention to another paper just published in Nature suggesting certain guidelines for investigating the importance and specificity of these genetic variants in order to make sure that they are truly pathogenic. I'm happy to announce that Baylor College of Medicine was just awarded a multi-million dollar award from NIH. We are one of 6 centers to pursue the undiagnosed disease program, so we'll have an opportunity to evaluate all these patients who are referred to us with undiagnosed diseases and use whole exome sequencing and whole genome sequencing to hopefully find the correct diagnosis. Okay, I'm going to shift to another topic, and I want to introduce it by showing you this patient, a 3-year-old boy with subacute onset of myalgias, frontal headache, malaise, vomiting, had obviously encephalopathic picture, dysarthria, motor aphasia, was diagnosed with viral encephalitis. He was hospitalized because of generalized seizures, dysautonomia. He had orofacial stereotypies, dystonic contractions of left side of the face, blepharospasm, dystonic flexion of the right hand, generalized chorea, opistotonic posturing. And here you can see his video. Again, you see the orofacial stereotypy and dystonia, the dystonic movement, especially in the left arm. He also had some opistotonic posturing. Clearly a severe encephalopathic disorder manifested by a variety of hyperkinetic movement disorders. We started on tetrabenazine, and within a week or so after starting tetrabenazine, he had marked improvement of the hyperkinetic disorder. So this patient is this subject number 3 in a series that we recently reported in movement disorders. And the purpose of this report was to draw attention to anti-NMDA receptor encephalitis, particularly in children. And what we try to point out is that this disorder can present with just about any movement disorder you can imagine. This patient had predominantly dystonia and stereotypy, but there were patients who had myarrhythmia, the slow rhythmical type movement, either in the face or in the limbs. Some patients had chorea, dystonia, ataxia, and so on. So the point is that if you see an individual with subacute onset of hyperkinetic movement disorder, think of anti-NMDA receptor encephalitis. This is often initially misdiagnosed, as it was in almost all our children. And again, I just want to emphasize the variety of hyperkinetic disorders that can be seen. This is a potentially life-threatening disorder. If it's not diagnosed early, the patients can die, and there have been some legal cases already where the diagnosis was not made in time and the individual actually died. One should consider looking at evidence of underlying tumors such as teratoma. Immunotherapy is obviously very effective, including solomedrol, IVIG, plasma exchange, and rituximab. And as I showed you in this case, tetrabenazine can be a very effective symptomatic treatment. Now, I highlighted children, and most of the individuals with NMDA encephalitis are children, but here's a report of adults with this disorder. About 5% of all adults of all people with MDR encephalitis are adults, and in contrast to the children, the adults tend to have lower severity of the disorder, but worse outcome because it's often misdiagnosed, so the diagnosis is delayed. And again, movement disorders play an important role as a presenting feature of this disorder. So that introduces the topic of autoimmune movement disorders, something we've been interested in and reviewed this in this article a couple of years ago. And one of the things that we try to do is to provide some classification for these autoimmune disorders. And we divided the different antibodies into those that were directed against intracellular antigens, and these are commonly paraneoplastic. Membrane antigens that are less commonly paraneoplastic, and then other antigen antibodies that are rarely paraneoplastic. And there's a whole host of antibodies, and this list grows almost weekly. And again, it's important to recognize that some of these autoimmune disorders may also be paraneoplastic. So finally, I just wanted to say a few words about treatment of hyperkinetic disorders, and I want to specifically focus on VMAT2 inhibitors. Now, I already mentioned tetrabenazine. Tetrabenazine is a drug that I've been very interested in. In 1979, I obtained an IND from the FDA and have treated thousands of patients with tetrabenazine. As you know, the primary mechanism of action of tetrabenazine is VMAT2 inhibition, and as a result, it causes presynaptic dopamine depletion. It was approved in the United States in 2008 for the treatment of chorea associated with Huntington disease. There are some other drugs that are tetrabenazine type analogs that are currently being investigated, at least in the United States, and that's why I thought it might be important to bring it to the attention of the European audience. One is the NBI 98854, which is a prodrug of alpha dihydrotetrabenazine, for an active metabolite of tetrabenazine, and then SD809, which is a deuterated tetrabenazine. So this is the NBI 98854 VMAT2 inhibitor. It has some advantages over tetrabenazine in that it has a lower PK variability. It can be administered as a QD or BID dose. It is much more active than the parent compound, and it is currently studied in tardive dyskinesia. We've been very interested in SD809 and are participating in some clinical trials of SD809, which is a deuterated tetrabenazine. So here you can see tetrabenazine is rapidly metabolized to active metabolites alpha hydrotetrabenazine, beta hydrotetrabenazine, and then it is metabolized by CYP2D6 to O-desmethyl hydrotetrabenazine. A deuterated tetrabenazine, which provides a stronger bond between the carbon and deuterium than the carbon-hydrogen bond, and it results in increased energy that's required to break the bond, and as a result there is an attenuated metabolism, which then results in increased active metabolites, namely the alpha and beta hydrotetrabenazine, which then results in increased area under the curve because of the attenuated CYP2D6 metabolism. So you can see here the sort of PK type data from tetrabenazine, the peaks and valleys, whereas deuterated tetrabenazine has lower frequency of these peaks, longer area, higher area under the curve, reduced Cmax, reduced dosing frequency, a lower rate rise, and probably a lower fluctuation. So it's one of the advantages of SD809 over tetrabenazine. There are currently several studies going on in the United States, mainly conducted by the Huntington Study Group and sponsored by OSPEX. This is a randomized double-blind placebo-controlled study of SD809 in the treatment of chorea associated with Huntington disease, and there is an open-label extension where patients are then rolled over to the SD809 from the double-blind study. And there's also a switch study where we take patients who are on a stable dose of tetrabenazine and switch them to SD809, and hope that soon we'll be able to report to you the results of this particular study. So there are many new developments in the treatment of Huntington disease, particularly the chorea associated with Huntington disease, and I just gave you some examples, but there are many others, and actually the pipeline in Huntington disease, in my opinion, is actually much healthier than what we see in Parkinson disease. As you heard yesterday, there was some pessimism expressed about the pipeline in Parkinson disease, but in Huntington disease, there are a number number of potential compounds and molecules that are currently being studied, and I just listed some of them, including the deutetrabenazine. You heard about pridopidine during Professor Carlson's lecture, as the first lecture of this Congress, but there are many other developments, and I think that the field of Huntington disease therapeutics is really quite exciting. Just a few words about medical treatment of dystonia. I'm not going to belabor that. Professor Berardelli already alluded to this review, which was an evidence-based review, where we looked at botulinum toxin in different indications, such as cervical dystonia, blepharospasm, and so on, and assigned levels of recommendation on the 4 types of botulinum toxin: ABO, ONA, INCO, RIMA, botulinum toxin, and you have to remember all these proprietary generic names in order to understand which type of botulinum toxin actually you are talking about. As you know, botulinum toxins, they all work through the snare proteins. They cleave SNAP25 or synaptobrevin or syntaxin. And this topic of snare was the topic that was discussed at the time when the Nobel Prizes were awarded just last year in 2013. It's timely to actually draw attention to those 3 individuals, Rotman, Sheckman, and Sudov, who received Nobel Prize in 2013 for their work on the snare proteins. And in one of the reviews, it says snares are key elements in the function of botulinum toxin, and dysfunction of snares plays a key role in Parkinson's disease and other neurologic and psychiatric disorders. So James Rotman also was a speaker at our Toxins 2012 meeting in Miami, and I guess I had a vision at the time that he will eventually get a Nobel Prize, so I want to take the opportunity to take a picture with him. This is probably as close as I will ever get to a Nobel Prize, but I thought it was a golden opportunity. So that reminds me to remind you about Toxins 2015, which is going to be our next major meeting on botulinum toxins. What is the answer to the question, can we diagnose them and treat them? Shakes, twists, and jerks. Well, I'd say yes, most of the time, but there's still so much to learn and so much to discover. This is the world's largest medical center, the Texas Medical Center. This is our new facility where we're going to be moving to in December. So I hope some of you will come and visit us. And I want to thank the President and the President-elect for introducing me and for giving me the honor to give this Stanley Fahn Lecture. So thank you very much.